Be so dry. Hey.
Okay, you. You're muted, you're muted.
Sorry, let's try that again. All right, so welcome to our 2022 Grand Rounds as part of our DM and Diploma examinations. My name is Arvind Ramnarayan. I'm the coordinator for the St. Augustine Campus Emergency Medicine Program, and I'm going to be moderating tonight. All right, on what I hope is going to be a very interesting Grand Rounds with a twist. We're going to have several different regional specialists who'll be talking to us on their top 5 tips for leadership and management within emergency medicine. Just some quick housekeeping before we get going. As is noted in the chat, right, you can leave your questions in the panel discussion chat on the Zoom site, or you can put it on the chat on the YouTube stream that we have running concurrently. And also, as a courtesy to our panelists, please leave your microphones on mute while the panelists are having their discussion. So on that note, I'm going to start off by introducing Dr. Jean Williams-Johnson. Dr. Johnson is currently our university examiner for the Mona campus in Jamaica. So Dr. Johnson, I will invite you to please give our welcome remarks.
Thank you very much, Arvind, and good afternoon and good evening, everyone. And it is indeed a pleasure and an honor for me to welcome you to this, our Grand Round webinar. It has been customary over the years that after the end of our DM exams, that we have a conference, seminar, webinar, since we're in this area of Zoom, where we invite our faculty and our external examiner, who in this instance is Professor William Sevcek from Alberta, Canada. I'm sure somebody else will introduce him more broadly as we progress. But thank you very much. Congratulations, even though that is still very secret, to those who I am saying congratulations to. And congratulations to the faculty at St. Augustine who have come together to allow us to be a part of this webinar this afternoon. So I'm sure you're going to have a good evening. I'm sure you're going to enjoy. And please remember all the housekeeping that Dr. Ramnarayan Arvind has just shared with us. So back over to you, Dr. Arvind Ramnarayan. Thank you.
Thank you, Jean. We're going to start off with a view from a small island emergency department. And our guest speaker is going to be Dr. Ian Sami. All right, he's a consultant in the Scarborough General Hospital in Tobago, which is a small island in Trinidad and Tobago. And he very modestly does not want me to let you all know that he is the originator of the DM program in emergency medicine in Trinidad and Tobago. So Dr. Sami, thank you for being part of this panel discussion, and the floor is yours.
Thanks very much, Arvind. So, you know, when I was asked to do this, I wondered what I should do and what I could do with a limited time and with the remit of the top 5 things. And I decided to take a slightly different approach. So the title of my talk is Leadership and Management in Emergency Medicine. And this quote, tell me, Ian, what is it that you actually do? I think sets the tone for what I'm going to talk about. So I'll tell you the little story. When I was a lecturer at UWI in St. Augustine, I started maybe a few years into the job. And the DM had just started in Trinidad. And I was at one of the dean's functions. And I was sat next to Professor Vijay Narayan Singh, who many of you will know is our Israeli the father of surgery, or one of the leaders in surgery in Trinidad. And he literally turned to me in all seriousness and asked me, tell me, Ian, what is it that you actually do? And that always stuck with me. This talk is actually based on conversation I had with a mentor of mine called Pete Driscoll, because we recognized that young people coming through the specialty sometimes struggle to understand where their place in life is. And usually that's not a clinical issue. When you're there on the floor, working at the coalface, you don't have time to think about, the meaning of life and that sort of shite. But when you are senior and part of your job is administrative and managerial, actually understanding where your niches can be very, very important. I think I hope that this talk would be of some use, particularly to our younger DM graduates who are just starting out their life as specialist medical officers, as consultants, as attending physicians, and who will be thrust into the world of management, leadership, administration, and politics. So it's not going to be a long talk, actually. And really, what I want to look at is who we are in emergency medicine and how that fits into our bigger role within the medical community, but actually just within the community as a whole. And I want us to think a little bit about this and about how defining who we are can help us fulfill our roles more meaningfully. So the first thing to say is, it's pretty obvious, but we are resuscitators. But sometimes we have to put that in perspective. Always remember, we are resuscitators, but probably 1%, or in some situations, maybe 2% of our patients require resuscitation. So it's an important life-saving skill that in truth and in fact, we rarely use. However, we are the people who are required to initiate resuscitation on acutely ill patients coming through our doors. And that resuscitation job crosses all specialties. So it may be trauma, it may be seriously unwell child, an older adult, a pregnant woman. And therefore, when we are resuscitating, we may feel to ourselves that we are meddling with other people's business. But in fact, the world of emergency medicine has got to a place now where we are the experts in this. By and large, we are the experts at cardiac life support, much more so than cardiologists or internists. ATLS still has this hilarious rule that the only person who could be a director at ATLS must be a trained surgeon. But my trained surgeons don't be in the resus room when we resuscitate their patients. What I want them to do is to get them to theater if we need that. And they understand that, and they leave me be and let me do what I have to do. The importance of this, though, is that in terms of the way your hospital functions, I actually think it is essential that that we take the helm when it comes to resuscitation training, resuscitation policies, and the organization of resuscitation within the organization. And that goes beyond the emergency room. We don't need to restrict ourselves when it comes to policy making just to the resuscitation room. This is a chance for us to get a hold in the wider hospital and show people what we do well and make the place a better place. On a slightly different but similar note, we are the guys who are always in the front of it in any mass casualty or major incident situation. And we have to take ownership of that. Now, it goes much far beyond just the fact that, if we have a mass casualty situation, we are the ones that end up taking the patients, organizing the system, making sure things run properly. Most of us don't really fully acknowledge this, but work in a mass casualty situation every day of our lives. We are always in a situation where the demand outstrips resources, and therefore we understand mass casualty thinking better than anybody else. Again, I think it's incumbent on us to make sure that wherever we work, we are an important part of the leadership when it comes to mass casualty or major incident planning for our hospitals, institutions, and communities. We are probably the last bastion of generalism within the hospital. And that's really important. There is nobody else past our doors who can look at and provide care for a patient holistically more than we do. And actually, all of us would have experienced what that means in these times of COVID, where you had COVID patients with appendicitis, or COVID patients with renal failure, respiratory failure, and they're diabetics and they have a nasty infected leg, and so on and so on and so on. And our experience was that people got really antsy about that, and they only wanted to deal with their part of the illness. And we were thrown back into the job that we are always thrown into, which is to look after the entire patient. Just as a little side note, that becomes even more important when we understand that our population is aging. And therefore, with an aging population, we don't have the luxury of having people come in with single system illnesses anymore. Older people will come in with 3 or 4 or 5 different things wrong with them, or a vague symptom that actually unearths dozens of problems going on with that patient. And if we don't have a generalist approach, the patient never gets the care they need. So again, when it comes to planning and leadership, we need to own the fact that we are generalists, work with the generalists in other places in the healthcare system, particularly primary care, to provide an excellent service for patients who do not live in the silos that our specialist colleagues live in. We are, because of the other things I spoke about, we are collaborators. We have no choice but to talk to, liaise with, get along with, cajole, coerce, and otherwise work with other people to get the job done. The big thing about this when it comes to being a specialist in a hospital is that you might as well understand that from the get-go, your management portfolio extends very far beyond the emergency department. It extends way into the hospital, but it also extends right out into the community as well. And to be a good emergency physician, you have to create and cultivate and encourage links with all these different places, specialists, interest groups. Similarly, we are team players, and we have a lot to teach other specialties about, particularly interprofessional working. So I have yet to work in an emergency department where there are cut and dry separations between nurses, doctors, attendants, enrolled nurses, physician assistants, or anybody else. We understand that the goal is excellent patient care, and we know that we all have to work together. Therefore, we have to put our egos aside. Why is this important? This is important because actually, although we don't know it, this is not the way for many other specialists. And that teamwork is something that enhances our roles and actually is something that we need to share with other people within the hospital and within the health service to make the thing work properly. Again, I'll go back to the thing about elderly care patients. older patients don't respect boundaries, and therefore to get a good outcome with an older patient, you need to be thinking about working together across primary, secondary, and tertiary care boundaries, but also across professionals so that the rehabilitation specialists, the emergency specialists, nurses, physiotherapists, pharmacists all work together. And we have experience in that. We must use it to improve the care for our patients. And on that note, finally, we are patient advocates. This is something we must embrace. Our entire specialty is based on the care of acutely ill, very frightened, often hopeless patients who need us to support them and who need somebody, well, us, to make sure that we help them navigate what is a very frightening episode in their life through the health service. I always tell my juniors, it is never, if I come on a ward round, the one thing I never want to hear is, what's wrong with that patient? And they tell me, oh, referred to medicine. Well, that is not what is wrong with the patient. It might actually be, but that's not what is wrong with the patient. That is who you refer the patient to. Once the patient is in our department, we have to keep an eye out and make sure they get in the care they need, and we can advocate for them. Think as well, as I said, about older people, but also people with disabilities and people who cannot speak out for themselves. Our job is to look after them. So I tried my best to stick to the 5 key points, and these were the 5 that I thought were the most important when it comes to thinking who we are and what we actually do. As I said, I really hope that for younger people in the specialty, thinking about this helps you on your path to becoming an effective specialist medical officer or attending physician or consultant. I'll leave you with a quote from this is a journalist from the early part of the 20th century. And I thought it really sums us up. Okay, and so with that, I will pass you back on to Arvind for our next speaker.
Thank you, Dr. Sami, for putting into words concepts that I'm sure all of us have to deal with on a daily basis in our jobs. And I'm sure it's something that all of us have thought about on one day or another. It's important for us to know, to have an identity of ourselves and our profession, because at the end of the day, we are our best advocates for our profession, because nobody else will really understand what we do. So moving forward from the view to a small island emergency department, we're going to have the view from the Coal Island Emergency Department. And our guest speaker is going to be Professor William Savchuk. Professor Savchuk is currently the chair of the Department of Emergency Medicine at the University of Alberta in Canada. And he is so helpful to us as part of our examinations as our external examiner that we have at this stage decided that we're going to adopt him and give him Caribbean residence. So Professor Savchuk, the floor is yours.
Thank you very, very kindly. I will come. I would love to come. I really appreciate the opportunity to speak to you today, and I will keep my Canadian accent to a minimum. I will try to speak slowly and articulate. My slides are this, and so I want to, like Ian, I really want to focus on the new graduates, the people just starting their careers. Ian and I didn't plan this, but I'm really glad he did and said what he did. He was at 30,000 feet looking at who we are. I'm going to take a microscopic look. We're going to go right down into your cells, and I'm going to talk about the 5 traits that over time from mentors of mine, including one of them is Ian Sami. He brought me here, to Trinidad at St. Augustine campus 2007 or 2008. And I was able to watch and see him as a leader. So these are traits of leaders and mentors of mine. And I've tried to embody them and live them. And so there are five. The first one is authenticity. And so authenticity is when you say and do things you actually believe. And you need to understand that. And it's that mission. And Ian talked about in the five, his 5 little circles of what we actually do. Our mission is, what, if you have a mission, it's what you do. A vision is what you aspire to be. And values, your core values are, why do we do what we do? What are our core beliefs? And you have to understand, for authenticity, you have to know the why. Why are you a patient advocate? Why are you a generalist? Why are you standing in the gap, doing difficult work with difficult patients at difficult times? Most people in emergency medicine know what we do. In fact, they should all do. We provide excellent emergency care, teaching, research. Less know how we do it. And so, you could say we use the best evidence, clinical decision rules, choosing wisely guidelines, and we use an amazing team of teachers and researchers to actually accomplish our jobs. Most of us don't know why. Really, you need to sit down and say why you do what you do. And so I start from the inside out. So that with authenticity, it's that why. You have to bleed this. This has to be who you are. And as a leader, this is how you lead. You lead with the why. So we have, and Ian mentioned this, we have the privilege to look after patients who are sick, who are injured, who are scared, having the worst days of their lives. And whether it's patient care, whether it's research, whether it's education, we are going to leave the community that we serve better than we found it. That's the why. How do we do that? By giving patients the care, the respect, and the dignity they deserve at their moments of greatest need. By educating and mentoring the next generation of healthcare providers, and by challenging the status quo and pushing the boundaries of knowledge. We just happen, the what, to provide amazing patient care, recognize teaching and cutting edge research. Join us. As a leader, you need to embody that authentic why we do what we do. Following on that is you need to practice empathy. Now, it's really easy to be concerned about output, when you're being, the managers, or why are there patient errors? Why is there burnout? It's easy to look at output and not at the people. I've learned the hard way that you need to think of ill before evil. You need to be concerned about your people, not their output. You need to think about, with that authentic view and that empathetic view, how can you as a leader create an environment that will allow your people to be their very, very best? And I think it's easy to forget that and focus on output. So you need to be authentic. You've got to practice empathy. And the other thing is that you need to listen. You need to listen to your team. I try to practice, and this is something that I've learned over the years, is to be the last to speak at a meeting. I need to actively listen to what's going on. You can set the stage, you as a leader, introduce the topic, but shut up. Just listen. How is it affecting the team? Who is struggling? Who needs support? Who has the ideas? And then more importantly, even who's not talking? And then you have to figure out, why aren't they talking? You're only as strong as your weakest link. And so it's critical that you listen to your team. The next thing is feedback. And, it's interesting. If I wrote down a few things, this would be a great OSCE exam question, just to, say, how would you give feedback? And you could easily list down, there's a number of things that you can do for that. But what's more important, what I'm more interested in, is how do you as a leader receive the feedback? Because dialogue is two ways. And so I really, some things like, you need to listen to the feedback given. And so that's why you shut up and you listen. And sometimes it's hard to hear. People are when things are going great, you give credit to everyone else. But when things are going bad, as the leader, it's your fault. You have to fall on that grenade. So you need to listen to people. You have to absorb that information. Try not to take it personally. And while you're listening to that, you have to be aware of your responses. Folded arms, playing on your phone, it just conveys that you're not interested. And that's not what you want. You want to avoid putting up barriers. You want to actively listen. You have to be open to the feedback that you're receiving. Sometimes it's not pleasant. Sometimes it's difficult to hear, but it's important that you listen to that, be receptive to it. And you really have to understand the message. So as you're listening, sometimes as they're stopped, asking clarifying questions about, okay, what exactly are they driving at? Just to make sure that you understand what's going on before you consider responding. And sometimes you can respond right away. Other times you need to reflect. You actually need to sit, reflect, what they said. Is there any kernel of truth to it? Have I been missing something? Have I been looking at things in one point too much and ignoring other things? And then you have to, how you respond, it's your decision, but seeking counsel to try to figure out how best to respond to that. And then the last thing about receiving feedback is a follow-up. Sometimes it is changing course. Other times it's arranging another meeting so that you can discuss what you're thinking about. And sometimes even then I need to get a third or a fourth opinion because the way forward isn't clear. And the last thing I want to talk about, so we've talked about authenticity, practicing empathy, listening, feedback. And the last one I want to talk about is encouraging both personal and team growth. The bottom line is you want to create an environment that you can transform your team. You want builders, not climbers. And there's this idea in some healthcare fields and in some healthcare authorities that we've got to get the right people. I hear that all the time. And I think that's wrong. It's how do you build a community? How do you build an environment that people will want to call us home? They are coming because of why we do what we do, not because of how we do or what we do. It's because if they come because of why we do, they believe in our mission and our vision and they share our values, they will pay you back with blood, sweat, and tears and loyalty. They're not just there for a paycheck. So you need to create that environment that transforms people. My grandmother, I'm a first generation Canadian. My parents came as small children from the old country, from the Czech Republic and the Ukraine. They left between the world wars, and seeing what's going on in Eastern Europe right now makes me sick to my stomach because I have family there. But my grandparents, especially my mom's side, English wasn't her first language, but her favorite English word, and her favorite word that translated to English is servant. And I could never understand that, because there's connotations about servants, it's second class or whatever. But, my grandmother, my Baba, she would always put usually it's a biblical quote to help her explain what you talk about. And, she would use Mark, that for even the Son of Man did not come to be raised up, but he came to serve and give his life as a ransom to many. And so I think having that servant mentality as a leader, that you're not just happy that the group is going to achieve its goals, but you're only going to be happy when each member of your group reaches his or her full potential, and you encourage that and you live that example by making yourself the best version of who you can be, the best leader, the best physician, the best, teammate. That's when you see true success with your team. So my 5 key things at a microscopic level that if I could encourage you to build within yourself would be to be authentic, to practice empathy, to listen actively to your team, encourage feedback both away and in, and then encourage growth personally and with your team. And with that, I'll hand it back to Arvind.
Thank you for that talk, Professor Savchek. I love the microscopic approach that Prof took towards that talk. You notice he used a lot of words, and clinician wasn't actually one of them. Right? We all understand that as part of our job, but a lot of the other things, the lot of traits that we see, right? Empathy, teamwork, active listening, those are things that really distinguish us as emergency physicians. Interestingly enough, they write whole books on those topics, and those books, they're not emergency medicine books. They're leadership books, they're MBA books, right? And people pay lots of money to learn those very same traits that all of us have to practice on a daily basis. When you take all of those traits and you add them to our general job, which has to do with throughput, flow, and we are the last set of generalists, it's no surprise that we start seeing all of these titles behind our names: medical director, clinical director, chair, program director, medical chief of staff. So that is going to take us straight in to our next speaker, like so much emergency physicians, because of our understanding of processes, have become the medical directors and the chief of staffs within our hospital system. So for a view from a medical director in a small island, I'm going to hand it over to Dr. Shani Williams, who's currently the clinical director of Queen Elizabeth Hospital in Barbados. Shani, welcome, and the floor is yours.
Thank you, everyone. Congrats to those who would have sat the exam today. And it's a pleasure and a privilege to speak amongst my colleagues. Y'all can hear me well, and you can see my screen?
Yes, yes.
Okay, I'm actually still at work, so apologies for being a bit distracted. And I want to say thanks to those who spoke before me, Prof. and Dr. Sami, because I hope without being too repetitive that I can re-emphasize and bring home some of the things that would have been mentioned before. So I'm still learning. I have a disclaimer. Let's see if I can move my slides forward. Okay, it's not moving. Let me stop share again. I'm still learning. Many of these things I didn't actually get from a book. So no matter how much training I thought I was doing, there are things that I would have learned from my colleagues and just from experience. And somehow my presentation isn't advancing. Why it was advancing all along. I'll do this one more time and then I'll abandon it if it doesn't work out. Just give me 1 second.
Dr. Ramnarine, while Dr. Shani Williams is checking out her sharing, do you want to discuss the question, Dr. Williams? Sorry, go ahead. Okay.
I can abandon it if it doesn't advance. I don't know why it's not advancing. Anyway, what I wanted to say was many of these skills you don't really get from a book.
Excuse me, Shady.
Yeah.
You advance. Look at the bottom right hand corner, bottom left hand corner of your slide.
Yes, there it is.
Yeah.
You see arrows?
Yes.
Yeah.
Not this part, the actual arrows. They'll go left and right.
I didn't realize I was so technologically behind. But anyway, thank you. I'll try it again. All right, so I had a little disclaimer to say that I was still learning, and many of the things I actually learned from my senior colleagues and some of my junior colleagues around me, technology being one of them. There are many different ways to doing things, and we really need to find and hone our skills as we advance in this profession. Again, apologies if I sound repetitive, but hopefully you'll find this topic useful. So my 5, I thought that I would want to emphasize that you really need to know yourself. It is true that the longer you work in A&E, you do gain some leadership skills. I mean, whether it is triaging the patients in front of you because you want to see the most urgent first, or dealing with the difficult patient, or giving bad news to relatives, or even being a team leader or a team member in a resuscitation. We need to spend some time to know ourselves and to decide what type of leader do we want to be. Have some sort of self-awareness and emotional intelligence. The emergency department is a unique place, as highlighted by the previous speakers. Can you mute, please, Dr. Blackett? I see you're not on mute. Our family, the emergency department is really part of our family structure, whether we're blood related or you are related just by situations and circumstances. So how do we manage and mentor and form and foster relationships in and around the people that we work with and the people that we serve? This slide just highlights, to be a leader, you really have to move. These two guys are just standing there. One is a talker, pretty in orange, and the other one is a thinker, procrastinator. You have to be a bit of both, and at sometimes you have to think, analyze, and strategize before you implement, and sometimes you actually have to communicate, articulate, and explain so that you can get your points across or have some sort of concepts towards demonstrating your vision. We really need to have a flexible leadership style. Some days you have to be autocratic, some days you have to be democratic, participatory, diplomatic. These things usually obviously depend on the situation, and we need to learn as we grow what format is appropriate for the circumstance. There's no, as I said before, textbook that will make you ace being a leader. But what we want to be is empowering and encouraging at all times. And there's sometimes you may actually have to do, or many times you may actually have to show. And we do it all the time when we're managing the patients and managing the shifts within our department. We may do it all at home as well, in our home environment. So sometimes we may actually have to lead within the silo of the department, and as said before, may need to lead up and across, where we're leading in the mass casualty situations across with all other specialties and our colleagues. We shouldn't ask people to do things that we think are inappropriate, unethical, or not prepared ourselves to be in a situation to do. So we really should concentrate on what it is we're asking of our team and the appropriateness thereof. So that's my number 2. Adaptive unconsciousness is a concept that I learned. And life skills teach you that, whether you have children at home who don't sleep at night, or you had a rough internship and you got called every 15 minutes in the wee hours of the morning. Those are skills that improve how you respond. As a consultant, you get called in the middle of the night, so you can wake up alert and be able to respond to the call and listen and pay attention to what the person is telling you on the other line. And so everything the trials and tribulations that we may go through, we don't recognize that it's all building blocks towards forming and fashioning who we become. Our clinical work is, as I said before, all about prioritizing, multitasking. When you run out of supplies, run out of bed space, equipment not working, how do we, do the MacGyver thing to get things to function? And that is how we adapt and unconsciously and shape how we are becoming leaders and seniors within the specialty. We have to accept also that the emergency department is not for everyone. So you may have a rapid turnover, and it may not be a reflection of the challenges in emergency department, but it may. And you should be encouraging persons to, find their niche and have the experience. Encourage them to come, have some experience, and then go to whatever specialty they think belong to them. And don't think that is a reflection necessarily of the challenges within the emergency department. Many times we see people years later who are dermatologists or others, low acuity specialties, who actually revere and enjoy and reflect on the times that they spent in emergency departments and accept that it had its time and its place, and it was well welcomed for them to become who they end up being. We should try to be encouraging to our support staff as well, housekeeping, orderly services, nursing, and encouraging them to be the best that they can be at all times. I think that's my next slide. Encouraging staff development, coaching, mentoring, sharing our skills. These are things that persons also recognize and acknowledge were beneficial. They may not have the wherewithal to decide that that I can be more, or I can progress, or I can advance in my profession, whatever it may be, but they may just need the push and the encouragement to do so. And usually that is the respect that you get over time as a leader and a mentor. Prof mentioned the why, and I do believe that as well. So encouraging staff development, and then my fifth is encouraging our own development. What is our mission? What is our vision? What are our values? What's the values of me personally, my team, and our organization? And let's see if they're all in a line and how we can improve and maintain the vision. We should always be continuously evaluating those three areas. You can't fix what you can't measure. So we should really try to have some kind of metrics to see if I'm getting better. You measure your weight if you're exercising on a program to see if you're getting better, along those examples. The two quotes that stick with me, one from Dr. Watson: you are, as emergency physician, you're a jack of all trades and a master when required. And yes, we are the masters of resuscitation, but we master many other things when required. And the other one is from a surgeon mentor of mine, is the Your Mama principle. What would your mother want as a patient, or what would your mother want of you as a professional? Your mother would look down on you and say, you're too tired, you're too stressed, you haven't eaten, you haven't done this, or you're speaking too rough. So reflect on that when you're doing your things and say, well, if your mother was behind you, what would you want? How would you want to project yourself in front of these persons, in front of, whether you're speaking to your colleagues, whether you're speaking to your patients? And then what would your mother want if she were a patient? Sitting on a bed for days, not eating, too cold, sitting on a chair waiting for a bed. These things usually augur well as you try to improve on how you improve on yourself as a professional. So we need to really continue monitoring, reevaluating where we are, where we're going, and if what we're doing, our mothers would be satisfied with. And I'll stop there. Thank you. And again, congrats to those who would have sat the exam.
Thank you very much, Dr. Williams, for that talk. Yes, it's very important to know where we come from and where we're going, especially since I believe our specialty, when we look at the responsibilities of emergency medicine, the responsibilities of the EM 20 years ago and the responsibilities of EM now are nothing like what it used to be, right? Our roles have changed and we've taken on so much more. So from this, we're going to move on. We're going to have our panel discussion. And apart from our previous three panelists, we're going to have two other additions, both of whom have titles such as clinical director, program director, because those are the type of people we have become, All right. So I'm also going to be introducing Dr. Simone French, who's currently the program director of Mona Campus in Jamaica. And I'm going to be introducing Dr. Krista Wells, who is the chief of service in the Princess Margaret Hospital in the Bahamas. Ladies and our previous panelists, welcome all. And I believe Dr. Paul will be fielding some of the questions to our panelists, if that is
Dr.
correct.
Ryan? Yes, I'm here.
Good evening.
So welcome all, and thank you all for participating in our grand rounds. I will hand it over to Dr. Paul and the panel.
Thanks very much. I like that. Your mama. I would change it from your mama to your mama. Thanks very much, Dr. Shani Williams. And just to add that we wanted to represent this session for Dr. The main person, would you believe I forgot his name? No, I'm just joking. Dr. Harold Watson, who is maybe retiring sometime this year or next year. I think he's coming to the end and he's trying to sort of like have succession planning to bring forth new leaders. And I really want to just dedicate this session and many other sessions we're gonna have further on for the rest of the year to him and for his leadership over the years. So it's my turn to dig deep and ask these 5 persons some of the questions you've asked already, but also a few of that I have come from. And I have a few questions from the Zoom, from the YouTube, and also from the other lecturers who were in the exam today, just to bring forth to have a deep dive to these specialists here tonight. So the first question, and I want to ask probably Shani Williams, your mama. I mean, it's really been throughout the entire panel if anybody wants to add in. But Shani, any definition of leadership per se? I mean, in terms of starting off, I know that most of us did our 5 points, but what would you say defines leadership or defines a leader? With your mask
Sorry,
on. Yeah.
sorry, Joanne. I had said I was walking away, but I heard you, so I had to run back. What defines a leader? Yeah, so you really need to be flexible and be willing to be a team leader when required and a team member as needed.
But what defines leadership though? What would be a definition of leadership? Not just the parts of it, but I want to throw it out probably to you, Dr. Sami and Dr. French. Dr. French had sort of like pushed me to ask you guys with this question. I think it's a great question to ask, start off with. What's your definition so far of leadership? Hard question.
Yes, very hard question. I will give my colleagues the opportunity to give their
I'll
perspective.
tell you,
I'm walking away for a minute. Give me a minute.
No problem.
I'll tell you that.
That's why it's about deep dive, guys. It's about, it's about presentation. It's about deep dive.
Yeah. So I'll tell you from my experience, what defines leadership is the requirement to lead. And that is very much an emergency medicine thing. So many of us are thrust into leadership positions. I always get a little worried when you come to us as a community. We got a lot of people coming to us over the decades I have worked. We have always had people coming to us to tell us about management and leadership. And yes, there's a lot that we need to learn, but I always get a little wary of what defines a leader, because I feel that then puts a limitation around us. And the truth is that most of us at some point, usually much earlier than we want it, are thrust into leadership positions. And what defines us and what defines our leadership characteristics really is the situation rather than anything. And I don't think that is necessarily a bad thing. I think that's just part of what it is to be an emergency physician.
Sure. Dr. French, Simone French, any thoughts about that question? Thank you very much, Sami. So it's about just grasping leadership. You're saying that it's just going forward and saying, okay, I'm leading a team here. Simone French?
Okay, hi, good evening. Are you hearing me?
Yes.
Okay, first of all, good evening to everyone on the panel and everyone who's listening in. So it is a difficult thing to define. And in thinking about it, I thought of the persons who went before me, who I considered leadership, persons like Dr. Naidu, Professor Archibald MacDonald, persons like Harold Watson, persons like yourself, Joanne, Ian, Sammy. And when I think of the persons who I consider to be leaders in whatever aspect of the field or whatever area they have been in, the thing that strikes me is the commonality, the common thread is that these persons had a vision. So managers are not required to have a vision of anything. Managers are required to keep the system going. They're required to follow the rules. They are required to keep the machinery functioning as specified, so to speak. But a leader is required to set a vision that the team can understand, especially, and this is a quality that is especially important when things are tough, because that's when it's hardest to lead, when resources are limited and things are tough, because then your team is tired, they are worn down, they are burnt out, and they need to be able to say, well, I don't see a way out of it, but Dr. Paul does. And I believe that she can take me through this. And and it's not about putting people on your back, because it's your team that's going to get to the other side, not you. But I think vision is a very important characteristic of leadership. And when I think of those people that I named, that is what comes to all of those people in whatever sphere in which they operate. They had a thought when they came into it of what they wanted it to be when they were through with it. I can distinctly recall, Jean will remember this, that when we entered the program, Professor MacDonald, there was a quotation from Emerson, Ralph Waldo Emerson. I'm trying to remember it exactly. I think it said, do not go where the path may lead, go instead where there is no path and lead a trail. That requires vision. That means that when you come into something when there is no framework, as a leader, you must create the framework. As opposed to a manager who comes into a department, yes, and there is a framework and you make that framework work. So for me, that's a practical way of thinking about it. A lot of what have been said is, I so relate, especially to what Shani said about your mama. What that was.
Love it, yeah, definitely.
Those are some of sort of my thoughts on some of the things that define good leadership. And just to say, the person in the room who has the title is not always the leader.
Yep, that's true.
And leadership is not always positive. And we can look in the world and see examples of bad leadership. And so each of us are charged with asking ourselves, in whatever sphere in which we operate, what kind of leader do we want to be? You don't have to be the head of department to be a leader. And in actual fact, what we are engaged in, all of us here as lecturers, are building the leaders of the future. And that work starts today. And we hope that our candidates are displaying those qualities as they develop. Thank you.
Excellent. Thank you very much. And just to realize all piggybacking, I love the connections, because we went from your mama to grasping leadership, and also talking about Professor MacDonald, and also the Senator Watson. So just going further, Prof, I'm incorporating the previous questions. I think Ian Sammy had asked Prof that when do you realize you need some help? Now, as leaders, obviously by going through, especially during the COVID pandemic, we were, plowing through and just trying to pick up more team, but sometimes you need outside help. So how do you recognize that? Not so much about just the passion and the fighting, collaborating, but when you realize you've reached your limit and you have to get some help, how do you as a leader realize that, Prof?
Great question, JP. I think there's a number of, and anybody that's in leadership, you get to a point where you're not sure. Your vision is taking you so far, but things have gone sideways. So the pandemic. So I wrote a few things that, the response. One is, one of my favorite quotes by, is doing the same thing again and again and expecting a different result is the definition of insanity. And so if you're seeing that, and it's usually your leadership, the management are saying, oh, do this, add a shift, move, and you realize this is never going to work. They're not listening to me. I need outside help. And that's where you start looking, who can I get with a fresh set of eyes, perspective, can bring in a different set of ideas, and then we can do it in a very dispassionate objective way. This is why this isn't going to work, but these are options that we could look at. Another thing I find is, especially pandemic or something, where there's a problem crosses borders. So, we are generalists in emergency medicine. We rub shoulders with all these other specialties. And sometimes we're at loggerheads. We're banging heads and we forget we're there for the patients, your mother. It doesn't sound good. It doesn't sound good when I say it. It doesn't sound good. It doesn't sound good. But, you're there for your grandmother, your baba, my baba. Yeah. So getting somebody that can cool the temperature down outside, it doesn't have any vested interest in what's going on here, but can come in and facilitate, make every group listen to each other, understand the problems from different perspectives, and help us work a way forward with the overarching, we're waving the flag of patient safety, of patient care, why we're in medicine, the whole thing, we're there to help people. Let's remember that and work together. So those are some ideas that, and my last one was just off the top of my head, is when you get to a point where something really bad is coming and you realize you've got no good options. If you go left, this is going to be a bomb. Go right, you're in the middle of a minefield. You need some help. And that's where I would say, who's gone through this, especially with your cohort. So you guys are lucky within your community. You can say Trinidad has been on fire with COVID, but they've come through the other side. They've done some pretty radical things, but that might work in Jamaica. Let's get Ian or let's get Arvind to come talk to us about what they learned. I hate the word learnings, but what they learned during that time, and using your friends and your colleagues. So that's what I would probably.
Thank you very much, Prof. Yeah. I have one more before I go on to Krista from Bahamas, but just to throw this onto the panel, I thought it was an interesting question. How can you teach empathy? Because the thing is that, to me, it's something you sort of like have innately, right? Of course, you can build it as a leader or build it as a consultant, but can you teach authentic empathy? Is a question I want to throw out to any of you guys. I know, that's what I'm here for, to bring the hard questions.
So sorry, go ahead, Simon.
So we have people who are sociopathic. Okay, so that's a different category. Unless you're a sociopath, you can learn empathy. And most people who do not exhibit empathy, it reflects, in my opinion, a lack of connection to the people around you, which may be because of your own difficulties, or, so if you don't know or recognize that your colleagues are having certain once you know, yes, and, we may not always, we come into the workplace, we may not always make those intimate connections, get to know our colleagues, but once we begin to, and this is what is a difficulty when in the pandemic, when you have people who used to come to meetings, who used to have mixers at work, and you be able to have potlucks. And now everything is online, and you come and you're so segregated. So the capacity to know has to be more intentional. It has to be more intentional, because some of the things the ways that we used to know were things we didn't think about. We had meetings where we were in rooms together and we could see somebody's face and say, what's up? How are you feeling today? Or they look sad. No, they're behind. Even when they look sad, they have a mask that actually allows them to hide in plain sight. And so for me, as I said, with the exception of persons who have a personality disorder, I believe that the majority of persons, once they, that can be taught skills to build empathy, and that a lot of it has to do with connections.
Sure, understand.
Yeah, let me flip that on its head. So when Paula was here as a lecturer,
This is Paula Newlands.
Yeah, my wife. She did some research on empathy in the medical students, in the undergrads. And the one thing that she learned from that is that you can unlearn empathy.
Sure.
So their empathy scores went down during their entire medical career. But the point is, if you can unlearn empathy, it suggests, as Simone says, you could learn it.
Yeah.
And, Bill made a point in the chat. It starts, it's not you know, I think maybe we might be thinking more learning in a kind of very traditional sense, but it is actually a lot more about just raising your awareness of what it is you want to do. Do you want to care for the people around you? Do you want to understand what they're going through? Do you want to be that shoulder that they could lean on? And if you want to do that, then I think, yes, you can. Then there are things that you can learn to help that situation.
And so Kristen, I wanted to ask you, I thought it was the intention of this session was just to bring the different aspects from different countries, different races, different genders, to give us a more holistic version. And I mean, in terms of leadership in Bahamas, what's your one tip? I mean, if you wanted to like have succession planning to your other consultants, what's your one tip you will give them? Especially, not just one tip, but especially for your unique Bahamian experience, because you're the only one. Most of us have one island or two islands, but you have like about, I don't know, I think it's about a good few hundreds, isn't it? And I mean, that to me,
islands.
how many, sorry?
700 islands and keys.
Right. And so that is a challenge by itself. What's your one tip, and how do you, as a leader, how do you manage with that entire aspect of having multiple islands you have to represent and lead for one island, one main island?
Thank you, Joanne. It was good listening to the other lecturers.
Yeah.
I respect individuals, my seniors, Dr. Ian Sami, we have Dr. Johnson, Burnett, and Watson, those who've gone on before. And as I reflect on one tip, and we have, when I say reflect, do some reflection, self-reflection.
Sure.
I was one of those individuals who, after graduating in November 2012, I felt like I was placed 18 months later to take on the role as program coordinator for Bahamas. I felt as though in 2017, becoming director of A&E, 3 years after becoming consultant, I felt as though I was placed in that position for that period of time. And as I look at my journey and I reflect, one of the tips of leadership that comes to mind that I would like to leave with those who are coming up would be to learn your workforce. And when I say learn your workforce, Simone mentioned having connections. When we look at our workforce, we must meet the needs of various generations of physicians. I actually thought I was one of the millennials, and I only recognize that I'm not. I was wondering, because we have this program going on in Bahamas where everybody is being nominated for the Millennial Award, and I tried to figure out why it wasn't me. And then I realized that I am no longer a millennial. But no, I'm not. So what's important is to meet the needs of the various generations of physicians in the emergency department. I found specifically, I did not have an issue as a leader with the clinical aspect, but how do I come up with strategies to engage my physicians? And across generations, I still have individuals, I still have baby boomers who over the age of 60 and have to recognize that, you know, you have unsociable hours. I have Generation X, you know, they were big on experience and management. And then I have these millennials who are innovative. And so I need to tailor and have strategic planning for those individuals. And then you have one or two who have made it into Generation Z with technology and internet. I am not techie. And so when you decide to change things, and I'll give you a simple example. I have someone who does the roster, and she decided to go from paperwork with the vacation leave to online. Right. And so she required that physicians book their vacation leave online. And we recognized that the baby boomers, they still had to use paper and give it to her to put it online. They're just not caught up. So you have different generations who are using technology, learning by technology, and you still have to strategize. How do you accommodate the other generations? And secondly, when I talk about learn your workforce, we talk about connections. We must learn, as Prof said, personalities. It helps us to work better as a team, knowing the strengths and weaknesses of our team members. And I'll give you a practical example. In 2018, Dr. Burnett put on a leadership seminar. This was my first leadership seminar. And I really thought that a leader should be a certain way. So I'm glad, Joanne, that you had us define what a leader is. And I discovered, and this is something that I've carried with me for the last 4 years, you must recognize the different color energies and know their strengths and weaknesses. So what I mean by that, everybody is different, and we must accept and respect that physicians are different. I'm red, I'm known as the fiery red, right? Strong leaders, high energy, I'm concerned with productivity, I take risk. If I want something done, I'll set a deadline. I want it done in 7 days. However, I learned that you have the blues, and they're the deep thinkers, they're focused, they pay attention, they're organized, they're cautious, like a Burnett. They do things, and blue says, let's do it right. So the blue, I might run out ahead as the fiery red, but it's actually the blue that slows me down and says, hey, let's check this just to make sure it's right. And then I respect members of my team who are greens. They're all about harmony and agreeing. They want us to just get along, and they're more concerned in a caring way. And then the yellows, they're saying, let's just do it together. And so I look at my workforce of physicians and I try to figure out where they all fall and how do I respect people who are different and make it work for the team because they bring strengths. Now, on the second point that you mentioned, how does that affect, how am I able to provide EM leadership in a country with multiple islands? So for those who don't know, Bahamas is made up of an archipelago of 700 islands and keys, and 17 of those islands are inhabited. Now, bear in mind, for 17 islands, with the population dispersed, there are only 2 public tertiary care facilities, one in Nassau and one in Freeport, Grand Bahama. And what we have to recognize is, as a leader and emergency medicine physician, it feels as though we are in charge or have oversight for all those islands, because the majority of them, they do not have a tertiary care. They would only have like a polyclinic that has a doctor and a nurse. And so they look at the emergency physicians at the Princess Margaret Hospital, those family islands. They call the ED and they ask for advice on patient management, whether or not they should transfer to the capital. And if we should advise to transfer to the capital, they want to know the mode of transfer. Lastly, I want to mention that during my time as head of department and Dr. Burnett's time, we had 3 mass casualties. One being the Exuma boat explosion in 2018, which required us to transfer those individuals to the capital. So you can imagine being on an island that has a clinic, you have critically ill patients that need to be transferred to the capital via air ambulance. And so I think the need for us as in the Bahamas is to train and disperse emergency physicians to those family islands so that you could have somebody critical there, with the experience. And also what makes us unique I always hear Jamaica, they're able to see patients and transfer to another hospital. Trinidad, you're able to do the same thing. We have one hospital in the capital and one in Grand Bahama. And those who are aware that after Hurricane Dorian in 2019, the hospital in Grand Bahama besides the emergency room, everything else was destroyed for a period of 18 months. So that really it added to our patient load. And so I think we need to be flexible, like people would have mentioned, and we need to be able to adapt to all changes in acute situations.
Thank you very much, Dr. Wells from Bahamas. And I guess I'll throw the next question to, I'm going to come back to Shani, your mama, but I want to throw the next question to Simone. In the same vein, in terms of differences, what's your one tip if you want to pass on succession planning to your other senior consultants, but also how do you deal with your variability, because you are the head of department for the ED that's in the only university hospital in the Caribbean. And so you have a higher level of academia that's expected. And I think the other difference you all may have, and I'm not sure I was correct about that. I know that to enter the university hospital, they may pay, but I'm not sure to enter the ED, they have to pay. So it's a public yet private entity sort of thing. And also it's high academia, you're the university hospital. So the two questions really. One, what's your one tip for succession planning? But two, how do you manage with those variables as a leader, as the HOD and the program director in your ED for University Hospital?
Okay, so I'm going to take the issue of the type of hospital. We're a strange animal, the University of the Hospital of the West Indies at Mona. So we are conceptualized as a public hospital, but in actual fact, depending on who you talk to, we're either public or, well, not private, but not public. Right, so, sure. So what you're referring to is that the government hospitals have a no user fee policy. So there's no fee to see the doctor. It's a bit of a, I'm trying to be very diplomatic. I'm not sure who's listening. So one may not pay fees to the institution, but then there are other issues that stem from that in terms of how investigations are garnered and how the patient, gets those investigations and whether in fact they have to go into their pocket. That being said, at the University Hospital of the West Indies, yes, there's a fee to see the doctor. However, in the emergency room, I want to be very clear, no patient is ever denied care because of money. So there is never a situation where someone is not seen because of an inability to pay. And in many instances, what is done is that the patient will be billed, and there is a whole department that is tasked with, following up that relative or patient to see if they can get payment at some time. Okay. There are a few things that we're required to pay for upfront, and even in those situations, there are avenues for those things to be provided in true emergencies with the intervention of a consultant. So we have pathways to deal with that. But it does mean that, to your point, University Hospital is viewed by the public as a different animal, and our quote unquote competitors are in actual fact private hospitals, because we are viewed in that way. And so persons come to us expecting that level of customer service, and they're expecting that level of service in general. And then it becomes very difficult because you're trying to provide that level of service when your resource inputs may not be what they should be. And there is this facade or this impression that things are new and shiny and all is well, when in actual fact, there are significant challenges. And those challenges are not always communicated directly to the public. So they come with that an expectation of, for want of a better word, champagne service on what we refer to on a SkyJuice platform. And so we do have our challenges. Customer service, in my time as head, you'll be aware this is my 5th year as head of department, and in my time as head, from the get-go, customer service has been the pillar, one of the central areas in which we would try to improve, and that and waiting times. And we have made some headway to a certain extent in terms of waiting time to see a patient. And we continue to believe that for the most part, we have improved with customer service, but it is challenging because the environment itself leaves a patient unhappy. I think it was Dr. Sami referred to patients spending days in the emergency department. And no matter how you smile with a relative and assure them and update them, 3 days later, 3 days later, that relative is unhappy. And you yourself as a doctor who has had to come and, you know, smile and say good morning and update them. And yes, I'll get medicine to come back and review you. And okay, just let me see if I can get another meal for you or update yet another relative. You yourself begin to feel a little bit of, you know, it begins to feel like, oh boy, you're almost afraid to go back there and talk to that relative again because you have nothing new to say to them that can alleviate what they really want, which is to be allowed to go to a comfortable ward with a. And I think, you know, if there are any of our administrators listening on, our failure to solve this problem is the thing that is hampering medicine, certainly in the country in which I reside. There is a big elephant in the room. It's a big ticket item. And the minister that solves it will be the minister that restores the hospital care to a more equitable platform. But I digress. Your second question had to do with academia.
Yeah. How do you deal with that expectation? I mean, you know, university hospital.
So how would I answer that question? So yes, we are a university hospital. We are charged with teaching medical students. We are charged with teaching graduate level students. And we are also charged with bringing concepts from academia to bear on real life problems. As it related to teaching ground to a halt, essentially. Everything went online in the pandemic, which interestingly, our department had already, just pre-pandemic, maybe a couple months before, had gone online with our staff meetings in-house for the general staff. So we have regular staff meetings that we do academic discussions at. So we had already, so that wasn't so much of a challenge conceptually. And there were some pros. We actually learned some lessons that, you know, people like logging on from home. It's easier. They don't have to drive up in traffic if they're not on duty. So there's some things to be gained. And I say that to say that we should keep our minds open to new solutions and embrace them, even if they're not things that, if you're not technological and somebody brings a technological solution, sometimes you just got to sit back and say, okay, let's try it and see. And sometimes you'll get gains that you didn't expect. We had to do, there was a weird tension, I guess, for me, between academia and practicality. So as we contended with the pandemic, obviously we all got into, I don't know how many conferences you logged on to. I know I logged on to several as we tried to use science, to bring science to bear to the problem and to design solutions almost overnight to address this new threat. But there were some of the solutions that were positive, and some of the academic sources were positing solutions that were not appropriate for us.
Right.
Things that we simply could never achieve. And so this is where we had, and I found that the voices in the room that were from the emergency medicine perspective, both in the ministry and at the level of my hospital, were the ones that brought some rationality to that discussion. This is not, I hear you, we want this resource, it's not gonna happen. So how can we look at other things from the literature, other ways in which we to come up with something that can work for us? And I think that mass casualty sensibility that Dr. Sami spoke about served us very well in that situation. We were able to do other things.
So you're saying the academia push really helped you guys through the pandemic. Just that
what I'm saying is that the principle that we would use, how academia informed the pandemic itself, is to go to the literature. You know, that's what we do, right? That's what academics do. We have a problem. You have a concept of what you want to do, and then you go to the literature and you see what others have done in other situations and try to apply those principles in your situation. And I want to stop here to say what we haven't done yet, and I hope you are all doing this, is one of the things we should be doing now as things settle, is we need to publish the systems that we have developed in our location, because the next generation will be looking to the literature if they have a problem. And we can then say, listen, Dr. Sami did it this way, Dr. Wells did it that way. There was a unique way that they went about it in Barbados that you could actually use. And so now that we're beginning to take a breath, I think it is very important that we begin to document some of the things that we have done, you know, whether here in Jamaica or elsewhere, that we think were unique solutions to old problems that got us through a very difficult period, things that may have never been conceptualized or done in that particular way. I think that's very important.
Yeah. And what's your one tip? Yeah, go ahead. You go ahead. You have one tip to your.
My tip doesn't have anything to do with academia. I will step back to say this. I know I spoke about vision. What I want to be clear is, as a leader, never worry about not knowing how. So I can give you so many examples where one simply had a concept. I need to get this done. So I know the end point I want to get to. I have no idea what the steps are that are going to get me there. But who is the bridge between me, my concept, and that vision? It's my team. And every single time that I went into a meeting and said, okay, or spoke, I can remember in one day was speaking to one of my chiefs on the floor and saying to her, you know, I need a tool to track. We have 40 odd patients outside and another 16 here. The way we've been doing it is not efficient. And literally within 3 days, she handed me a tool using a free app that we now rely on as a standard to track patients with or without a surge. And that's because I didn't hold it to myself, and I did not make it my personal responsibility to get from the beginning to the end. I knew what I wanted to do, but then you go and you find people, because we don't know it all. You asked, I think it was Shani, how do you know if you're trying to do it all, you're not going to do it well. The trick is to go to the right people. Go to the right people, and many times those people are right beside you. And many times just letting people know what you want, somebody will raise their hand and say, I can help with that. I know how to do that. Or they'll send you a little WhatsApp and say, you know, Dr. French, there's this little thing we could do. Would you like me to do that?
Mm-hmm.
Send me something. And that morphs into something that becomes the actual solution. So I just wanted to be clear that in saying that leaders have vision, it is not your entire, you're not responsible for the conceptualization and the operationalization of that vision, because you have people, you have a team, and your team is happy to help. And it actually makes them feel empowered, because now they are a part of this thing. And, you know, they can take ownership and say, you know, of that system that they have helped create, and they will help to steward it. They will help to steward it. If somebody tries to come in and mess with it, they'll say, hold on, stop. No, not today. So just that would be my tip, if I could say there's a tip.
Thank you very much, Dr. Wells and Dr. French. You know, I couldn't put you all to present before, but it's great having you guys there. Now, I just have a few more. I mean, we've been being hit by all the questions, so I'm going to go through really fast. I mean, Shani, are you back? I know you were driving. Yeah, great, right, no problem. Question though, but Shani, I'll start with you. Do you think, and again, I know these are hard questions, I'm here to just throw it at you guys in deep dive. Do you think enough is being done in these small islands to teach leadership and mentor and have succession planning? I mean, we're small. It seems that, and I mean, you will agree, and I'm sure Ian, Sam, you speak about this before. Do you agree that sometimes it's the same person is doing multiple things, the same things over and over, the same leaders all the time, and people get accustomed to having that? Do you think we're doing enough to pass on the baton?
Right. So I'm not as verbose as the others. So my answer to that is no. And because enough is not a number, my answer to that is no. So enough is relative, right?
Yeah.
No, I don't think so. And we need to sit back and decide what is the problem in 2022, 2023 that we're trying to solve. When emergency medicine program started with the dynamic trio, 20, 30 years ago, the problem they were trying to solve was to make sure that the islands had skills, and the emergency medicine program reached the region. I think we're reaching the region, but we need to now, go on their shoulders and take it a little bit further. Krista has her challenges of her 700 island 17 that she's trying to populate with emergency physicians in every street corner. And we have our challenge where we only have one island with one hospital and only 2 consultants. And we're graduating all of these residents in emergency physician specialists. So what do we do? What is the problem we're trying to solve? We won't have all of our staff as emergency physician specialists because that will then stagnate everything. So we're now, we need to look back and say, well, we need subspecialties. That's great. We would like a peds emerge. We would like trauma, ultrasound, all the other subspecialties, but can we pay them? How do we get that step first? So we need to make sure that we have enough subspecialties for our population and the appropriate remuneration. If not, they're going to go to cold, to cold Canada.
Right.
And that's fine. We may say, fine, we are training for export and let the residents know from the beginning. We are training you, go somewhere else, plan to go somewhere else, do your USMLEs, do your Canadian exams, or plan to go other places in the region where there's a need. So we have to be clear in our mind what we're doing from day one now, 2022, 2023, so that the residents, when they be 4 years later, don't become frustrated because they're stagnated and there's nowhere else for them to go. Yes, within our country, there's the disaster planning, there's the administration, there's the hierarchy within our hospital. And also there are urgent care centers that are popping up. We have one now, which is a mobile one. That too will soon become saturated. So we really need to constantly reevaluate 3 to 5 years. What are we doing with our residents? Let's not frustrate them and let's encourage them, motivate them, coach them into what opportunities are available. And it doesn't have to stay with emergency medicine full stop. That is a platform for several other things. And that is what we need to do. But I don't think we're doing it consistently enough and forcefully enough. Yeah.
Ian, Sammy, do you think we're doing enough to pass that baton? Thank you very much, Shane.
Yeah, it's a good question. I mean, just to pick up on something that Shani was saying, I think there is something that possibly at a regional level, we need to figure out how we do this strategically, but it might be a generational thing. If you look at other countries, so North America, Europe for sure, but actually now places like South Africa, a lot of the Asian countries, over a generation, there has been a move to the acceptance that emergency medicine is not something that can be light on top. We are supposed to be a multi-consultant specialty. We are supposed to be run by and led by trained specialists. But when you sat where we are, it's very difficult to get people to see that vision. However, we have to keep pushing that. We have to, and it will happen. You know, the example that we need to look closely at is anesthesia. When I was a junior doctor, most anesthetics were just given by house officers, and you had a few consultants trying to run the whole place. And then things started to change. And now, even in our countries, you're not going to find a hospital with just 2 anesthetists because it's recognized that that is a high-risk area and you need properly trained people to be actually doing the job, not just supervising from afar. That will take time. I know it is difficult, but we have to keep our eye on the ball and try, you know, it might mean for our generation. I mean, the other thing about getting frustrated about people not taking up leadership battles, I have told you guys this privately, and I am quite willing to say this publicly. I try my best to hand over the baton to other people. Absolutely. But at the end of the day, I have an ace up my sleeve. Sometime within the next 10 years, I will do something that will make other people leave. I will clutch my chest and I will fall down on the ground dead. And I'm not saying that lightly. That's what my family does before they reach 70. They die of a heart attack. And when I do that, somebody else have to leave, and I don't have to worry about it. So, that's just the reality of life. People need to pick up the baton, and we need to help them do that. We need to help them find their place and take some leadership.
Sure. All right, we have time, and so I had a slew of questions, but I've just been going through the side. I want to just choose two. So the question I have for all the panel persons, just very shortly, very succinctly, one story that stuck with you throughout your career that had the most impact on you in your formation as being a leader. So just one story, just very succinctly, who, what, where, short story, what was the most impactful thing that made you the leader you are today, or had the impact on your growth? We'll start with Prof.
Oh, really quickly. One that comes to mind was, it got me really into academics. I did a lot of training in the United States, and love their gun battles. And I was on call at Shock Trauma in Baltimore at our platoon, and I remember about the 4th gunshot wound we saw that night, and I've size 9 hands. 4th time I was in somebody's chest, and it was a 19-year-old kid that we pronounced dead. And I remember taking my gloves off and slamming him into the garbage can. And time of death. And I remember September 12th was my birthday at 005 hours, September 12th. And I remember thinking, Christ, this is on my birthday and this kid's dead. And it really, and at that point I knew, and I had to say to myself in a quiet area, that I was addicted to treatment. And so my area of expertise in academia is injury prevention, especially in children. And I knew at that point that I'm addicted to treatment. Chest tubes, thoracotomies are sexy. All this stuff is sexy, but that was somebody's child that should never have been there. And their lives are irrevocably changed because of that. And I, as a healthcare provider, my passion for helping change things, that really, I remember thinking, I got to do something about this. I don't ever want to see this again. And unfortunately, I've been unsuccessful over the last 20 years, but I'm working at it. So that's in my mind.
Just to deviate a little bit, Prof, have the recent shootings also brought it back to you? I mean,
Yeah. And Joanne, I do pediatrics, you as well. And it is terrible. It's horrible. I just think I would never see this after Sandy Hook, 20 white kids. Yeah. Now, like it just, if they can't change, my mom's an American, I guess we need to drink rum for this, but yes, it brought it back.
Yeah, definitely. Yeah. Not just brought it back, but unchanged, where it's happening, but no change at all. And that's the thing you were saying. It's like, if you see yourself doing the same thing over and over again, it just, it's crazy. Krista, any one story from your end? I mean, I'm going to ask everyone, but just shortly.
As a leader?
Yeah, what one story, one moment that impacted you as a leader that still stays with you even now?
I would say it had to have been the start of the COVID-19 pandemic, when most individuals, whether they were healthcare workers or just laymen, that everybody was afraid.
Sure.
And I felt as though that I had to create a plan. I was the captain of the ship, and I needed to sail the ship safely to shore. I didn't know how. It was a new concept. And that was the most impactful period, because I saw my staff look up to me, and they trusted me to steer them home safely. So sure. That was the most impactful.
Cool. Appreciated. Shani? Hi, Shani.
I'm here. So my story was, I was a resident actually, and it was in the 90s. And so my first rotation would have been anesthesia, and being competitive, David Bayer, I don't know if he's on the call, yes he is, and I had a competition who would do the most intubations in anesthesia. So we organized our schedule that we would do 2 a day, 2 times 5 days a week, which is 10 times 10 weeks. In 10 weeks, we should get 100, whoever reached 100 first. So we were going obstetric clinic, obstetric theater, main theater. And we were trying to make sure that we got our 100 intubations before 10 weeks. I can't remember who won. He will say he, I will say me. Anyway, so I think that at the end of anesthesia, I was fairly good and comfortable with intubations. And then I became a shift leader. But I think it was an SHO then still as well. But I became a shift leader soon thereafter. And one day we had near drownings off of Browns Beach. And 2 teenage boys came in, needed intubation. But it was a 3-man shift. I was the only person skilled in intubation, few nurses and nobody else. So I had to figure out, how am I going to run 2 resuscitations at the same time, and how we're going to get this done. So I did airway 1, teaching somebody to do airway 2. All right, it's time to intubate 1, and then run to intubate the other one, then resuscitation. So yes, needless to say, I probably vomited at the end. I can't remember. But it was very stressful. And at that time, the post-resuscitation debriefing wasn't a consistent thing, but we made sure we did one then. And I recognize the importance of being part of that team. Eyes on the prize, 2 people needed urgent need, how we're going to manage it. And we just had to get our act together and everyone be part of that team. We had to incorporate non-medical people to document and do the notes. And we trained somebody to do CPR at the time, chest compressions, and one of the earlies were doing it. I mean, they had some idea, they've seen it before, but they actually were now doing these things for the first time. And I would never forget that, because it was really a stressful event. One of them actually went on to the ICU. The other one, unfortunately, had died, but that was useful. And then I fast forwarded that experience. So 1 year later, I left Barbados and went to the UK, and I was suturing behind a screen. I was the shift leader then, with staff grade position I think I had. And I tell this story almost every resuscitation course I do. So I apologize for those who've heard it 50 times.
Okay, I haven't heard it, so.
Right. So there was a outpatient who came to get her prescription filled, and she collapsed at the door. And it was we were doing precordial thumps at that time. So the security guard did a precordial thump, dragged her, put her on the resuscitation bed, and they called for Dr. Williams, please report to whatever room. By the time I put down my sharps and scrubbed and went to the room, the nurse had up the IV, defibrillated the patient, gave the patient TPA, that's what they were giving at the time, running it through. And the defibrillation put her back in normal sinus. And all I had to do was write the notes. And I was like, excellent, this is wonderful. So I went from high stress in one couple months before to a team working at its best a couple months afterwards. And those 2 experiences made me say, this is what we want. This is our goal. We want everybody to be able to function towards one objective.
Got you. Excellent. So you mean just a team just running smoothly, almost like the whole lean concept, right? The Japanese lean concept. Love it. French? One short, sorry.
You are really asking tough questions.
I am.
Tough questions. And one is tempted to mention the pandemic, but the truth is, I will tell you this. First of all, I never, as a resident, conceptual. In actual fact, I would routinely say I never want to do administration. I would routinely say I am a clinician, and I thought I was a pretty sharp ER doc too. Dr. Edwards, I can recall some of the comments Dr. Edwards has made to me over the years. I have softened, she tells me. And I was hot stuff as a chief resident, I thought, on the ball. And never, admin never. And my place is here on the floor. I can recall though, one shift coming on, and this is when I was just early consultancy. And there was a child, and again, I will do what Shani did and apologize, because I give this story whenever I teach ESI. So it's at the front of the PowerPoint. So there's a young child, very sick child, and I walked by, and the child was placed in a relatively low, she was not placed in the high acuity area. And at the time we were not using it. And I just took one look at this child, grabbed the child and took her to the resource area. And the short version is that the child had to be admitted, was very, very ill, died within 24 hours. And I went back for the notes to try to understand why this sick child was placed in this relatively low acuity area, which led me to question, and I'm using these words very deliberately for those listening, it led me to question how the system could have allowed this to happen, which led me to research, to your point about academia, triage systems, not just defined at 5 level, which we knew was sexy at the time, but the 5 level that I felt, given the staffing mix, etc., at my hospital, the circumstances in which I work, and to propose to the then head of department to have a discussion. And it took us just about a year and a half to go from finding the tool, having the research required, some commitments and keep putting it in front of people. But then we got to the point where we adopted ESI within my department, and subsequently was invited to a discussion by the Ministry of Health a couple years later, which led to discussions around the implementation, so that now the Emergency Severity Index is the accepted triage tool island-wide, which means that we can now have one tool that is across the hospitals that can be audited at the level of, which is what I'm hoping the ministry will do next, so that we can audit triage as in and of itself. I say that to say that that situation offended me at my core. It was untenable, and I did not. So it then taught me that I had that capacity, and I had that aspect that I previously would not have ascribed to myself, and that was then extended into something that went bigger and is not at the national level. I say that to say that some of you listening may feel that you don't have that capacity. You do. And what Dr. Sami said is absolutely true. I did not choose my current leadership position as head of department. Not for a second. I didn't put up my hand and say, yeah, good, it's me, right? It came to me through a series of circumstances. But by that time, I knew I had, some skills. I had some concerns about others. And then you develop yourself through what Shani mentioned, which is the process of the self-reflection, being honest with yourself, knowing what you're not great at, and being willing to try to build yourself in those areas while leveraging what you're good at. So that would be my story.
Oh, that's really good. Ian Sami?
You're really asking hard questions tonight.
Yeah, the last one is an easier question, but I really wanted to, I want to get a more, I want to let the audience see the leaders, the inside and out, and I want them to see themselves in the leaders. So yeah. So,
yeah, I'm going to give you a very personal story. When I was a young consultant, I think maybe it's not a big picture story, but it is about yourself, and also experiencing something and then learning about yourself. So I was a very young consultant in the UK. I had started a job where I trained. So my mentor, Peter Skull, was there. He was one of the other consultants. And it was very early on. It would have been the first year I worked there. It was the first winter. I started working in February, which is very cold. It might have even been the first month. They pulled a 7-year-old child from the ship canal, frozen stiff, brought in, having CPR, took over, started CPR, put in chest drains, warm water irrigation, trying to set up for bypass, trying external warming, trying warm saline infusion. We did everything. This child was asystolic. I was the consultant on duty. Pete was there with me in the resource room. We had been going for about 45 minutes. Everybody was distraught. And I turned to him and I said, what should I do? And he just looked at me and he said, you're the boss. You decide. And he did not make the decision for me. Anyway, eventually the child died and we had to deal with that. There are two things I learned about that. One is going back to Simone's point about what I had said. Because of the nature of our work, we are thrust into these situations. We don't go looking for them. Maybe we do in a kind of funny kind of way, but we don't really go looking for them. And it is part of the nature of our leadership that we have to be able to take on these things and do something. Because I had an entire shift of staff who could not work after that. I had to make the decision, and then I had to bring them back to where they needed to be. But there was another thing I learned from that years after, which is I got to the stage where I was on the other side of that. I was the person looking at my junior consultant saying, "You're the boss. And I will tell you that is the hardest thing to do." These are like your children. And there comes a time when your child grows up and you cannot treat them like a baby. And it is the hardest thing to do. And I don't know what's the point of that story, but there you go.
Let me just go to you with, so if I can try to paraphrase then. So I guess your point is that sometimes you just have to let it go then. You just gotta say, here, what, I've passed the baton to the junior person, I'm just gonna let it go.
So you have to, and it's a deliberate act. It's not a by the way thing. It is, I am passing this on, and I have to not only give you the opportunity, but give you the authority. You do it. This is you. This is not me.
So it means sometimes as a leader, we actually have to let it go.
Yep, absolutely.
And just say, okay, it's your turn now. So let me just end with my last question, and I'll start with you, Dr. Sami. So we speak about work-life balance, and especially during COVID, and we teach and advise our juniors, try to make sure you're balanced and stuff, because you want to have your immune system good, to make sure you're healthy. How do you maintain your balance as a leader?
Well, what all of you need to do is fire the walk, move to a small island in the Caribbean where the beach is 5 minutes away, and make that your priority. Buy a bicycle. Bicycle always helps. No, but seriously though, you know, as your life goes on, you have to readjust your priorities. And I will tell you without any shame, but you know this because you work close enough with me, my work is not my priority. I have reached the stage where my work is not my priority. And that's a good thing.
So essentially your advice in terms of that balance is just to make sure your work is either one of your main priorities or not the main priority.
And also understand that it will shift with time. There's a time in your life when it is, and there's a time in your life when you're not wanting it to be, and that doesn't happen overnight. You have to work towards each stage of that journey. Okay,
so we have some things to remember, guys. Your mama, right? And buy a bicycle, right? I'll reverse the whole thing. Simone French, quickly, because I know that we out of time, but I just want to end with this one. What do you do to maintain your balance, especially during this COVID time? I know most of us are juggling private practice, family, work, university. How do you maintain?
Right, so I'm not the most organized person inherently, and I am typically a procrastinator. However, it has become imperative that one organizes one's time, and one must make a very clear distinction between what is actually urgent and important. So there are many things that will clamor for your attention when you're in a leadership role, but many of those things do not require your immediate attention. And so one of the strategies I have used is I actually have a very distinct time diary. I have a place for certain kinds of discussions. And if someone tries to have those discussions with me outside of that forum, I gently redirect them to Wednesdays at 10 o'clock, because it really was a challenge for me. I think I have adult ADHD that's undiagnosed. And so I have a natural tendency to jump at things and to respond to every message. And it was becoming very maladaptive. It was getting in the way of my achieving and focusing on one thing at a time and getting it done. So by creating these places, then I can say, well, okay, that's great. Heard you. We're going to have a meeting about that. We have that session every Monday at 3. So check me then. I do want to say that this concept of work-life balance is something that is misunderstood. Nobody's life is completely balanced. And if you selected in medicine as a career, particularly emergency medicine as a subspecialty, then you selected a certain degree of imbalance, but as Dr. Sammy says, in the different phases of life that it's going to look different. So my young doctors graduating from the program spent 2 to 3 years just getting really good at being a technically competent clinician. And they're going to then move into phases of varying degrees of administration, as you heard Krista define her path. And eventually you're going to get to a point where those things come almost automatically. They're almost at the level of what did my friend say about unconsciousness?
Adaptive unconsciousness.
Adaptive unconsciousness, you know. So it gets to the point where certain things clinically are at that level, but no, you're learning administration. And I want to remind persons that just like you have a path to learn, you have a learning curve clinically, you have a learning curve administratively. And a mistake I made starting out was I intended to be, great on day one. And a colleague of mine who's in management, actually in the private sector, sat me down and said to me, look, it takes a year to a year and a half to get good in a role like this. Relax.
Mm-hmm. Sure.
Be okay with not being perfect 100% of the time. You'll get the important things right. Some of them will go a little bit sideways and and a few will fall off, and then you'll fix that next year. And you have to give yourself that growing room as somebody who is adapting to that admin role at that level. And it's okay. And of course, as I said, you have a lot of people. I still call Dr. Williams Johnson. I could not have done what I have done today without the support of people like Jean who have walked that path before. And the first year I almost felt embarrassed to call her one more time. Mm-hmm. But guess what? The support was there. And those of us who move on will of course support those who come.
Sure. So let me just ask you though, Dr. French, what do you do for fun?
Well, what I do for fun, I love nature, and I do not get to the beach often enough. I had intentions this week, they're disappearing. I do go to the gym most times, at least 2 to 3 times a week. Sure. And I think that's important. But I do love nature. So walking in nature, water, anything to do with water, friends and family, which disappeared in the pandemic, right? And for us as doctors, it's kind of weird because whereas you'd say to people, well, yes, keep in touch with friends and family. I didn't see my mother for months, but from a distance, because I was deathly afraid working in the hospital that I would take something to her that would be, injurious to her. And I'm sure everybody had that experience, but we've learned to leverage WhatsApp groups and Zoom calls. I have a friend group that meets regularly every 2 weeks on Zoom, and we found ways to use technology to sort of alleviate or to find new ways to socialize. So that's what I do. And Netflix.
So really and truly you sectionize and make sure you have it in compartments to make sure it's as balanced as possible.
I learned initially I didn't, and I really got overwhelmed, seriously overwhelmed. And by creating a place for everything, don't get me wrong, it's not perfect, eh? A few things will slip out, but it's far better than not having some sort of structure to fit things in.
Sure, gotcha. Shani Williams?
Yes, please.
Yeah, just last
so
question.
My advice is do as I say, not as I do.
Your mama, yes. So after your mama,
you're
gonna give me that, Shani Williams.
So Yeah, so what we have here is a situation where there are several studies that show that the life of an emergency physician working in an emergency department with the intensity that you do as an attending from residency to close to burnout, if nothing changes, is 15 years.
Yeah.
And we're up in 20s now, right? So I actually used the opportunity for the Fulbright scholarship. I actually was running away from emergency department as opposed to running towards something. That's really what I was doing, running away, because I felt as though I had COVID environment, pandemic, the position I was in, trying to coordinate things throughout the hospital. It was very, very stressful.
Mhm.
And those 5-6 months, I worked 7 days a week, but 3 days face-to-face teaching. The other 4 days was not as intensive because I had to learn what I was teaching, but I was in front of a TV, binge watching NCIS and Law and Order SVU while trying to learn some healthcare policy and different things. So I used those 5 months to regroup and reset. I was able to eat on time. I was able to exercise. I was able to watch TV. I was able to sleep a whole night without my phone ringing. I think that happened every day for about 4 months, that I was able to, after 10 o'clock, my phone didn't ring till about 5 o'clock in the morning. And then I knew it was somebody at home. At first I was a little nervous and anxious, but it was nothing but no bad news.
Right.
I had one bad episode of bad news where my aunt, who was in New York, had a stroke. And she spent 3 days in her emergency department waiting to get a bed on the board, was on ICU for 5 days, and then couldn't get to a rehab center. Well, we spent 3 more days in the ICU while they were trying to organize her insurance. But anyway, she's fine. So just to show you that New York also has the same problems that we do.
Yep, definitely. Mhm.
So yeah, so the imbalance of work-life balance, you really have to take it in your age and stage. I'm now at the stage where my children are big and they ignore me completely. So I really need to reevaluate myself and coordinate the things that I enjoy. I always try to find a hobby, and every season I would say, yes, I'm going to play the guitar. I have a guitar, never played it. Yes, I'm going, I'm going to paint. My husband bought me a huge paint set. I gave it to my daughter. So you really have to find the time to get the hobbies done and make sure that you're doing the healthy lifestyle things, because this environment will consume you completely.
So 15 years old, and then they usually say every 5 years the EM position, you should tweak somehow, either go into some other aspect. You can't be just going straight up, right? They always mention admin, some other thing, or you just
something else. Yeah.
Cool. I'll finish Dr. Wells. Prof, what do you do to make yourself as balanced as possible?
I love listening. It's interesting, similar problems no matter where you are. Now, Ian, I'm going to come visit Parle Touvier, is one of my favorite places, and you're the wildlife preserve on Tobago and Birds of Paradise Island, one of my favorite places in the Western Hemisphere. I'm coming. So I really think balance is important. And I agree that Simone's right. We went into this for chaos. We like chaos. We like putting order on chaos, and it's going to bleed into your life. The most important thing, though, is for the young, our next generation, I can't see your faces, but you have to put your 10,000 hours in to be an expert in what you're doing. Then I love the idea of always reinventing yourself so that you're full-time at the coalface will wear you out. We see things, we feel things, we deal with things that nobody else in the medical profession deals with, and that will weigh you down. Your soul can only take so many hits. So you have to take your burnout. PTSD is real, and you have to take that seriously. So have a healthy out of life. I'm a farmer. I grew up on a ranch and a farmer, so I ride a horse better than I walk. Mind you, you haven't seen me walk. That's not saying much if you haven't seen me walk, but I love to garden. I live right on a river valley. I'm always out for walks and runs. But the thing that I've learned, kudos to everybody, is learning to say no. And that's hard to say. We're trying to get you into doing academics or doing leadership, but you have to learn to say no. One of my mentors, he's since retired, a guy named Dave Petrie. I call them Petrie's rules of three. He was an emergency physician for years on the east coast of Canada in Halifax. And his three rules, you say no. If you don't have two of these three, you walk away. It doesn't matter what it is. The first rule is it has to make you excited. It has to put a fire in your belly. Two, you have to get paid. Now, that can be money, it can be accolades, it can be a diploma, it can be a publication. And the last so it's got to be a fire, and it has to make a difference. The third one, it has to make a difference. And you can define that how you will. But if you have two of the three, consider it. If you only have one of the three, you kindly say no and walk away from it. And I've tried to do that for the last 20, 25 years. And I missed a few opportunities, but I've never lost any sleep over that.
So money, so paid, difference, and passion.
Fire in your belly. It's got to be something that really turns your crank.
Sure, sure. And we'll end with the youngest, the most millennium of all of the presenters here. Krista, last words. How can you, as a leader, how do you want to advise your juniors how to have balance, especially COVID, post-COVID, and monkeypox, whatever pox and whatever else is coming?
Right. So sorry, I moved to a different location. So number one, don't have meetings in the evening. That's number one. Two,
we're ending soon. We're running right after the last.
Right? So there are a couple of things. When I took the leadership role, I found myself constantly on my phone. I felt as though I was having palpitations. I was texting at 3 o'clock in the morning because I just had to get it done. And then I recognized that it's important to have balance. And so those who know me, I love basketball. Like right now, the first game started, the championship. I love to eat, so I'm a foodie. I do not work on Friday evenings. I always do something. I have a day set aside where I do something that's outside of medicine. I love to sing, so I go to karaoke's. I have a karaoke machine, and I make a practice never to carry my laptop in the house from Friday to Monday, to force me to wind down. I spend a lot of time with family. Every Sunday we gather, and that's what I enjoy, so that when I get back to another week, I am refreshed. And so I think I'm living my best life right now.
And on that, Dr. Rhonda Ryan, after your mama, adaptive unconsciousness, after the great panelists here we have had, 5 top leaders who I would have picked up so many ideas from. I really appreciate this discussion. I know it's been longer than we expected, but I think it was really, really high quality. And I really want to thank all of you guys. And Arvind, back to you. Thank you very much.
Thank you all very much, panel. I do want to take to say that I absolutely do not agree with Dr. French, though. Sky juice over champagne any day of the week, right? As you all well know.
You're welcome at my emergency department then, sir. You'll get sky juice all day.
Thank you very much, madam. So as a final thing, we want to have Dr. Jill Williams-Johnson give our closing and thanks. All right. And I would like to also thank all our panelists for taking part in this discussion. So Dr. Williams-Johnson, over to you.
Thank you very much, Arvind. It is indeed a pleasure for me to say thanks to all the presenters and the panelists. What a wonderful 2 hours we have had this afternoon. I'm sure everybody has benefited tremendously from what was said and what was discussed. And I'm sure everybody has at least one pearl. Eric is a pearl person, at least one pearl that they can take away from this. I'd like to say thanks to Ian, Dr. Sammy, to Bill, Prof. We're extremely happy to have you with us. Certainly, we always enjoy hearing from you. And I know Ian is looking forward to that promised visit. Thank you, Dr. Williams. Shani, we certainly enjoyed hearing from you and seeing you and learning that you're having a good Fulbright experience. Mhm. And then the other members of the panel, Dr. Wells, Krista, Dr. French Simone, and Joanne for taking us through that discussion. It really was a fabulous afternoon, Dr. Caroline. I see that in the chat. We have learned that we must know ourselves. We must be flexible leaders. I like that 3 points in terms of when you should really think about saying no, get excited. You must get paid, whether by money, accolades, or diploma, and what you're about to do should make a difference. And somebody also told us that when we have things to do, if we can't measure what it is that needs to be done, then we can't really fix it. And of course, Dr. Sammy brought us through the discussion as to what are we, what are emergency physicians, and we're advocates, we're generalists, we're team players, we're collaborators, all very important points that were brought out by the team. And before I close, I should say thanks to Joanne for mentioning that we're dedicating this time to Dr. Harold Watson. I think I see as if he's in the chat, and we're happy for that. And thank you all so much. Continue to do what you do. I think we have had a really good evening as we discussed what the 5 tips for leadership and management as presented by our various speakers and emergency physicians all. But thank you very much. And with that, I think I just say have a good evening, have a good night, and continue doing what you're doing and continue to enjoy this journey and its various permutations. As Dr. Sammy told us, we adapt at the varying times of our lives. Our priorities change as we progress. But thank you very much and have a good evening, everybody. It was really an excellent time.
Good night, everyone.
Take care, bye.